Thanks, Jeff. It's an honor to be here and a great pleasure. I'm always excited when I actually get to come someplace else that has mountains instead of, not that there's anything wrong with Kansas City, but I do have a love for mountains, and this is one of ours in the Northwest. Jeff is a fabulous photographer, so I told him that I pepper my talks with some of my own work. And last year I had the pleasure, we have 5 volcanoes, this is one of them, and I had the pleasure with my 19-year-old son to finally summit the last of the 5. So I can now say I've been on top of all 5 of them. This is our northernmost, near the Canadian border. This is actually Mount Baker. Most people think this is Rainier when they see the picture, but it's our Mount Baker. So I'm going to talk about disagreements between parents and providers, or parents and providers today, and do so in a way that hopefully provides kind of a framework for thinking about those disagreements, both from sort of a practical perspective, but also from a problem-solving perspective. And I'm going to try to cover both aspects of that. I have nothing to disclose, no industry relationships, and I think you have all seen the practice gaps and desired results, so I'm not going to spend a lot of time on that slide. But all of these, the sorts of things we're going to talk about today generally start with a patient, and in our case, that patient is usually a child, most of the time not capable of providing his or her own assessment of what he or she thinks is in their best interest, and so we're dealing with surrogate decision makers to some degree. And I like to start these kind of discussions with a case to root this, and some of you heard me talk about Dennis Lindbergh last night. He is one of these cases that sort of challenged our paradigms for thinking about this in Seattle. And I'm using his name because what I'm telling you is all in the public domain. It's not because I am an ethicist who forgot to learn about confidentiality. So Dennis came to us as a 14-year-old. He was living in the custody of his aunt who had legal guardianship. His parents' rights had been revoked several years prior. They were both addicted to drugs, and Child Protective Services in Idaho had finally terminated their parental rights because they didn't feel they could take adequate care of their son. So Dennis went to live in northwestern Washington with his aunt. She was a practicing Jehovah's Witness. He began going to church with her and developed quite a strong connection to the church, and when he turned 14, became a member. It was only shortly thereafter that he was diagnosed with acute lymphoblastic leukemia. He was given about a 70% chance of cure with chemotherapy, which would also require transfusions, and consented to the treatment. There was never, to my knowledge, an explicit consent to transfusions. I'm not sure if that was assumed or just sort of glossed over in the initial conversations. But predictably, once he got chemotherapy and his counts started to drop, he made it very clear that he would not accept chemotherapy to the point where he would pull his IV out if they tried to transfuse him. And his aunt obviously also refused to provide any kind of consent. Now, his biological parents, who no longer had any parental rights, heard about this and made their objection known. And ultimately, this was brought to a Skagit County Superior Court judge who declared him a mature minor, and I'll talk a little bit about that in a minute. And he died within a few days. So Dennis was actually one of those individuals who was actually allowed to die because of both a decision on the part of his legal decision maker and ultimately his own. Now, that's a very dramatic form of sort of a parent who refuses to accept our recommendations, but every day we face similar ones. Anybody who, maybe you don't have this problem in Utah, we certainly do in Washington, but anybody who tries to immunize children has probably encountered a parent who will not allow that. And whereas the stakes may not be quite as high as it was with Dennis, it's a similar problem. So the first thing I want to point out is there are 2 kinds of disagreements, and the way we approach these are actually different. And there's a lot of, most people don't recognize this difference, but it's pragmatically and to some degree ethically, but certainly legally, there's a big difference between parents who refuse to consent to the kinds of treatment we're recommending or the kinds of testing we're recommending, and parents who are asking for something that we may not be comfortable providing them. And I'll talk about both of these, the latter one fairly briefly. But these are different and require a different approach. So I'm going to start with the parents who decline our recommendations. And the ethics of this is framed by the law, and the two are really pretty much entwined, and it's very important to recognize that. Physicians cannot treat a competent adult except in an emergency without that person's permission. That is considered, the legal term for that is a battery. It's actually considered a legal charge, and theoretically, you can be charged with a battery if you try to do something to a child without the parent's permission. So there's a very bright line here from a legal perspective. The only way you can treat a child without the parent's permission is with some authorization from the state. And again, I'm sort of accepting the emergency situations where there may be exceptions on a state-by-state basis. But for the most part, you need some kind of state authorization. And that varies from jurisdiction to jurisdiction. It may involve pulling child protective services in. It may involve getting a court order. It depends on sort of what the mechanisms are in your jurisdiction. But the bottom line is the state needs to authorize this sort of treatment in most cases. And so that's the legal constraint. And so for most of these parents, the question we're really asking is not so much the legal one, would it be okay to override the parent's decision, or should we? But it's the legal one, which is, does this cross some kind of a legal threshold where it's reasonable to involve the state if I can't get the parents to do what I feel they need to do for their child's welfare? So communication and persuasion are clearly the preferred mechanisms. It's what we rely on. You can bet that those sorts of mechanisms were appealed to in Dennis's case as much as possible. But there will always be cases where, despite our best efforts and the best efforts of the best communicators, we still face a parent who will not consent. Diagnosing their reasons can be helpful. But again, in the background is always this question, at what point do we involve the state if we can't get them to consent? And as I go through this, think about the two examples I've given you. There's Dennis Lindbergh's case, where the majority of people at least have an intuitive sense that this seems to cross the line, maybe not everybody. And then there's the vaccination situation, where, to my knowledge, there are very few clinicians who actually would call CPS about that or try to get a court order to force a child to be immunized, barring some extraordinary circumstance like a massive disease outbreak with lots of people dying and having disability as a result. And smallpox might be an example of such a disease. So what are the legal limits of parental authority? The law does give parents, as well as ethics, gives parents a fair amount of authority to make decisions for their kids. And in general, from a legal perspective, the case we have to make is that parents have somehow neglected their child medically. You can try to make a case of parental incompetence if you've practiced, pediatrics for very long. You've all encountered incompetent parents. You know that. Fortunately, the vast majority of the time we can convince them to do what we need to do. And I'm not actually aware of any cases where somebody has actually tried to challenge parental decision-making competence as a way around this problem. So, and I think it's an extraordinarily difficult bar to make. You would really need somebody who probably has got a psychiatric illness and is not being treated to pull that off. So most of the time we're relying on this notion of neglect, which some people have defined as parents failing to act in the best interest of the child. And I'm going to challenge that notion a little bit, because I don't think we actually or can or should be using the best interest of the child as our standard for involving the state on a neglect basis. I think the standard is actually lower than that, or higher than that. best interest is what we ask parents to do. We ask them to look out for the best interests of their children. And quite frankly, parents do that even when they disagree with us. I mean, those parents who don't want to vaccinate their kids aren't doing it to be obstinate. They're doing it because they really think there's something about that decision that is in their child's interest to not get vaccinated. And Dennis's aunt was the same way. She was looking after his soul, and in her mind, his best interest meant not getting treated for low blood counts. So best interest doesn't really entirely solve this. It makes for a great guidance principle. It's how we base our decisions. We try to make decisions on the recommendations rather on the basis of what we think is in the child's best interest, which is why the oncologist strongly recommended chemotherapy for Dennis Lindbergh, and which is why most of us strongly recommend vaccinations for the kids we see in our practices. But again, my argument is that the best interest standard is not an interference standard, that there's a gray area between where what we would call the best interest of a child and where we would say this goes too far. And I think the vaccination case provides an example of that gray area. Most of us would say it's in the best interest of a child to get vaccinated, but most would also say, but it doesn't reach the threshold, whatever that is, and I'll talk about what I think that is, that I would call CPS when a parent doesn't do it. So what should an interference standard look like? Well, you know, again, just to think about the best interest standard, this has been just sort of routinely adopted because it was convenient. The reality is it was never invented for the purpose of deciding when we should think about interfering with parental decisions. It was really, it has its origins in family law, and it was really a mechanism for judges to think about how to adjudicate custody disputes, for example, which home would be the best for the child, and they tend to be fairly binary decisions. You got to make a choice, so you choose the best one for the child. And in the cases that we're confronted with in the medical context, it's a little stickier because there is value, there's social value in allowing parents to have a little more leeway than that simple sort of dichotomous choice. But nonetheless, that standard has sort of been blindly adopted through the years, and I think created a lot of trouble for people. I first started thinking about this issue probably 20 years ago, doing ethics consults and talking to our intensivists who would say, I don't see what the problem is here. The parents are clearly not doing what's in the best interest of the child, and yet it wasn't clear that this really crossed a line where you would involve the state. The best interest standard tends to be something described as something almost mathematical. Brock and Buchanan, who are some of the leading thinkers about surrogate decision-making, define it as acting so as to promote maximally the good of the individual. You know, we kind of ask parents to do that, but we all know that they can't do that in all situations. So it may be that it's an aspirational goal, but again, we don't call CPS every time we perceive that a parent is not actually promoting maximally the good of their child. I don't think I did that when my kids were, I know I didn't do that when my kids were growing up, and I probably still am not doing that. Beecham and Childress define it quite mathematically. A surrogate decision maker must determine the highest net benefit among the available options, assigning different weights to interests the patient has in each option and discounting or subtracting inherent risks or costs. It's a nice mathematical equation. I have yet to meet anybody who actually knows what kind of numbers you plug into that equation, so it makes it a little difficult. But the best interest standard presents some problems when you're trying to decide whether to interfere with a parental decision. First of all, people do define the interests of other people differently. I mean, what we may feel is in a child's best interest may not be able to factor in all of the things a family or a parent is factoring in. And it's not entirely clear that families can or should be always highlighting the best interests of their child or children. Sometimes you have to make choices between your children, so one kid gets the good stuff and the others don't because you can't divide it up. And so parents are all the time having to subjugate the interests of one child for another, or sometimes maybe both children for the interests of the family. And And we accept that. We also know that as I mentioned, most parents don't always act in ways that optimize the interests of their children, and we're usually okay with that as well. I mean, I see lots of sort of even parenting kinds of activities that I think are probably not the greatest ones for kids, and yet we let parents do those sorts of things. And the reality is that even though courts, they love to talk about the best interests of children, but when you actually look below the surface, and I've looked at as many of the court cases as I can find and read the opinions, most of the time the court they're making their decision on some other basis. They talk about the best interest standard, but they actually require a fairly high standard. The way Ken Wing puts it is, that they're reluctant to require medical treatment for any child except where immediate action is necessary and where the potential for harm is rather serious. And so even the courts really give parents a lot of leeway, and you see that in many of the medical cases. So here is one of the best definitions of neglect I've found. The basis for state action has been defined as a failure to provide, and this is an important word, the minimum quality of care which the community will tolerate. That's not best interests. That's something different. Another shot from my neck of the woods. Okay, so what's an appropriate interference principle? My argument is that it's actually something called the harm principle. The reason I advocate the harm principle is in part because, as I mentioned before, the constraint placed on what we can do medically is really a legal standard. And so it's fair to ask, what's the ethical underpinning for appropriate legal action? And John Stuart Mill actually answered that question in his small book on liberty, when he said the only purpose for which power can be rightfully exercised over any member of a civilized community, so think somehow the state's acting to interfere with a parent's decision-making decision-making for their child, against that person's will, is to prevent harm to others, in this case the child. That person's own good, either physical or moral, is not a sufficient warrant. So what Mill is really saying here is that state action may be justified when one individual, in this case the parent, makes a decision or does something that places others, in this case the child, at substantial risk of serious harm. Not trivial harms, not a tiny risk, substantial risk of serious harm. That's part of the reason we tolerate the decision not to vaccinate kids. Because when you actually, we don't think it's the best thing for kids, but when you actually look at what the risk is, it's pretty low for most kids. Not zero, but it's pretty low for most kids. Most parents will get away with that decision, so we tolerate it. As a general rule, if you're planning to interfere, it has to be effective at preventing the harm. Now, if you think about Dennis Lindbergh's case, providing him with blood will almost certainly prevent the harm of dying from a hematocrit that won't sustain life. So in that case, it passes that test, and it passes the first one as well. Most people would argue that by refusing a blood transfusion in that case, you're placing him at significant risk of serious harm, and I think that's a pretty easy case to make. Joel Feinberg says the last criterion that needs to be met is whether there are options less intrusive to individual liberty that are available short of calling basically CPS or getting a court order. And that's really where persuasion and communication come in. So, where is that threshold? Different people have placed it in different places. Lainey Ross talks about the deprivation of basic needs is when we should be interfering with parents. Joel Feinberg, who is one of the premier experts on the harm principle, has defined it as interfering with the interests necessary for more ultimate goals like physical health and vigor, integrity and normal functioning of one's body, the absence of absorbing pain and suffering or grotesque disfigurement, minimal intellectual acuity, and emotional stability. And the AAP has just sort of settled on substantial risk of serious harm, all of which are saying more or less the same thing. So these are the conditions that I would suggest need to be met before you interfere with somebody like Dennis's aunt in making a decision to refuse care, or any parent making a decision to refuse some kind of treatment or therapeutic or diagnostic option for their child. That they're placing their child at significant risk of serious harm. Interference is necessary to prevent that harm. It's likely to prevent that harm. and it's not associated with a similar risk of similarly serious harms. So the chemotherapy cases get interesting, and there are plenty of the cancer cases that are in the literature, and so the question is always, okay, change the numbers. How does, let's say Dennis has a 50% chance, or a 30% chance of surviving, or a 10% chance. And I don't have a mathematical answer to that question, but what I will say is the lower you get, the more courts are likely to not interfere with a parent's decision. At 10%, I think you'd be lucky to find a court that would actually side with the medical team. At 30%, there are many courts who would side with parents. And the dividing line, it's not a formal one, there's nothing official about it, but when you read the cases, most of the time, if it's above 50%, they will side with the medical team. If it's below 50%, they're much more inclined to side with parents in a chemotherapy decision. Now, what makes chemotherapy unique is it's a toxic therapy, so judges will factor that in. They will say, well, sure, you can save his life, but look what you're putting him through in the way to get there. That alone can kill him. That's going to make him miserable. He's going to be nauseated. He's going to develop other potential side effects and may end up in the intensive care unit and all this other stuff. And they will factor those in that sort of proportionality requirement to sort of figure out, does this cross the line? When you're talking about a blood transfusion, that line can go a lot lower. Because at least the sort of medical, you can argue about the spiritual damage, but the medical damage of a blood transfusion and the risks are very low compared to something even like chemotherapy. I've talked about no less intrusive alternatives, and then I threw in two other tests which I like to use, which have specific purposes. So before, and I will say I use this all the time, so because, I work in an ER where parents refuse to do what I want them to do all the time. And, so when I'm attending in the ER, my standard case is, the 1-month-old baby who really needs a spinal tap and the parents don't want the spinal tap. Or at least I think they need a spinal tap, or the resident thinks they need a spinal tap. And so I'm usually getting the warning. The resident says, well, I talked to the parents about a septic workup and they don't want the spinal tap. So I know what I'm doing. I know what I'm facing when I go in the room. And I work through this before I go into the room. Because one of the things I want to know before I go into the room is this a case I will push to the wall? Or is this a case where ultimately I'm going to allow the parents to prevail? And that's going to depend a little bit on what the numbers are. And I will say the threshold has changed since I started practicing than, say, where it was 30 years ago. I'm much less inclined to interfere than I might have been before, with the exception being a baby who actually looks sick. And that's the one I might push to the wall. But that test of generalizability is an important one. And it's designed to get an implicit bias. So, one of the things I ask when I go in the room is, if the answer to those previous questions is yes, I would interfere with these parents in their decision. The next question I ask is, okay, what if they look just like me? Would I still interfere with that decision? In other words, let's say they live in my neighborhood, dad's a professor at the university, they're white, middle class, make the same income, both college-educated professionals. Would I still make the choice to interfere? And if the answer is no, bias has probably crept in there somewhere, because the answer shouldn't be no, because the answer should be the same to the 5 questions above, and that's what's relevant. So that's the test of generalizability. The test of publicity got thrown in there because as I was thinking about these cases, for whatever reason, when we get these cases at Seattle Children's, they end up in the newspaper, and our PR people are all in a tizzy about it, and I imagine yours is similar to that. And so they one of the questions that people always ask is, yeah, but what if we get in the newspaper, by calling CPS or getting a court order? And my answer to that is, well, you very well might get in the newspaper, and that shouldn't be a problem as long as you can defend what you have just worked through in coming to that decision. And it seems to me if you can defend it, if you've got good reasons, you should be able to communicate that to the press. The PR people don't always buy that, but it's just a way of saying this isn't just my opinion, this is a reasoned opinion that other people can actually agree with. So that's just to say that I think that's how we should make these decisions. And again, the bottom line decision is really not what I think this child needs. That's more of a clinical decision. It's, will I interfere with the parents if they won't do what I think they need to do? So the next question, and Dennis's case raises this, is does it matter if it's a religious objection? And the short answer is no, it doesn't. A lot of people think somehow maybe the religious reasons are privileged. Some people are more likely to interfere with religious reasons. But again, look at the test I just laid out with the harm principle. It says nothing about the parents' reasons for this decision. All it says is they have placed their child at significant risk of serious harm. And it doesn't matter if they're doing that in Dennis's case, if his aunt is doing that in Dennis's case because she's a Jehovah's Witness or because she's a biologist who has some quirky ideas about prions that are previously undescribed that exist in the blood that may damage us, and we don't know how that's happening just yet. I'm making that up. The reason really doesn't matter. Where the reason matters actually is when you're trying to work with these parents, diagnosing their refusal. It's really helpful for me to know that the reason Dennis's aunt is opposed to blood transfusions is because she has this religious belief. And if I understand that religion a little better, it may help my approach in trying to convince them or come up with some non-coercive solution to the problem. But it's not relevant in making a decision as to whether at the end of the day I will call Child Protective Services or get a court order. So what about older kids? William Blake said, neither youth nor childhood is folly or incapacity. Some children are fools and so are some old men. I think this is that ride at Disney, California. And by the way, I hate Disneyland. I don't like crowds. I'd rather be standing alone on the top of a mountain than in crowded Disneyland. But somehow I ended up on this. This is that one that loops around through Mickey Mouse's ears and makes you completely nauseated and sick. What's important to notice here is that neither my wife or kids are on this ride with me. I think it was about the 6th time I was doing it. So when this sort of algorithm is kind of what I follow. When refusing provider recommendations, the first question we ask is, does the patient themselves have legal decision-making authority? Adults do. If the answer is yes, is there reason to believe the patient doesn't possess adequate capacity to make the decision in question? Rarely will that be the case, and so we follow their wishes. If, on the other hand, it is the case, if we really think their decision-making is impaired, then we may follow the procedures that are usually laid out in state law regarding competency determinations. Now, if the patient doesn't have legal decision-making, which is true for most kids and most adolescents, we identify a legal decision-maker, or in the case of adults, if they have a durable power of attorney or living will. And if they don't have a living will or a durable power, then we use the harm principle to decide whether to challenge surrogate decisions. So where do adolescents fall in this? Well, here's what I would say. Short of legal situations where an adolescent is emancipated, and they're pretty few and far between. If you look at most emancipation laws, it's pretty hard for an adolescent to be truly emancipated under the law. Because most of the things that emancipate you would actually require somebody to be of legal age. Being in the military is one of them, by the way, and you can't be in the military till you're 18. And in most states, that's the legal age, where you can make medical decisions for yourself too. Some states emancipate you if you're married. So if you can marry at 16, you may have a couple years where you're emancipated, and you are your legal decision maker, and then your decisions are to be respected under the law, unless you can make a case that this person's not competent. But some people still feel that there are adolescents, like Dennis, who maybe should be allowed to have something to say about this that actually is legally binding, and we call those mature minors. And in Dennis's case, the judge did declare him a mature minor. Now, why did that happen? That happened because if you think of the aunt as the legal decision maker and you run through the mechanism or the process I just talked about, the conclusion you come to is we will challenge her decision. So The next step in Dennis's case was, okay, but should he be granted decision-making authority? So what the judge is really doing there is saying, I would probably interfere with the aunt's decision in this case, but I need to make a determination about whether Dennis is a mature minor, because if he is, he gets to make the decision, and I don't. Which is why Dennis's case was not overridden. If Dennis had been 7, I can almost guarantee this judge would have agreed with the medical team, he would have ended up getting transfused and ended up being treated. But he's 14, and so there was this sense that we need to decide whether he might have the capacity to make legal decisions. I think that decision was wrong. I don't blame the judge for that, because I don't think the judge actually had the data that he needed to make that decision. But knowing what we know about how adolescents' brains work, I think it's not well advised to allow them to make decisions that we wouldn't allow their parents to make. We know adolescents are capable of making rational decisions. There's data that's 35 to 40 years old that shows that they can do that. They're capable of it. But we also know, anybody who's had an adolescence certainly knows this, that although they're capable of it, there are lots of situations in which they're clearly not using it. And as a matter of fact, they seem incapable of using it. My daughter calls that freaking out. We know adolescents are more likely to act impulsively without a full consideration of future consequences. We know that their brains are designed to favor to sensation seek, to look for thrills, to do things that make them feel good than an adult might be, present company excluded. And we also know that their brains are wired so that they're much more inclined to be prone to things like peer pressure. And that's because social connection is very important to that adolescent brain. And so adolescents are much more likely to make decisions sort of based on the way they feel than by engaging their prefrontal cortexes and sort of thinking through the consequences of what I might do here. So my feeling is that adolescents should be involved in these discussions. They should be aware of what we're doing. We should recognize that they're developing capacity. But I also think there need to be limits. And in cases like Dennis, I think the limit is, we're not letting your aunt make this decision on your behalf. I don't think we should let you make this decision either. And so my bottom line for adolescents is, again, I don't think we should allow a parent to make a decision on I don't think we should allow an adolescent to make a decision in situations where the harm principle would suggest we wouldn't let their legal decision maker make that decision. So what about when they dissent? So Dennis said, and Dennis is 6 feet tall and he's a big guy. Dennis said, if you try to transfuse me, I will pull my line out. And so one of the questions that comes up is, okay, so you've worked through this and the conclusion you've come to is we would seek to override the aunt's decision, we would seek to not recognize Dennis as a mature minor and therefore transfuse him. But what are you going to do when he physically resists that? And I think that does change the equation to some degree, particularly if it's going to be a repeated event. What you have to do in that case is factor in the not insignificant harm you may be doing to him by physically forcing him, restraining him to accomplish something. I don't have an easy answer for that. I will say that I would be reluctant to do that. But here's the other thing. I'm fairly familiar with most of the cases that have come up in this arena with adolescents, and most of them are oncology cases that end up sort of having some kind of legal document drawn up or media attention drawn to them. And in most of those cases, the adolescent has actually said they would physically resist, and in none of those cases have they actually done that. And so what you find is that what an adolescent says they will do is often not what they actually will do. They actually become quite acquiescent when an authority figure like a judge or a physician says, I'm sorry, I know you don't want to do this, but I am not going to let you die today. And so this is what we're going to do. And most of them will acquiesce at that point and not actually physically resist. And I suspect that would have been the case with Dennis had it gone in that direction. Okay, so a brief word about the other side of the coin. So we've talked about parental refusals. What about parental requests that seem to go beyond what we're comfortable doing with? My bottom line here is I think for the most part we should carefully consider them. We should treat them respectfully, but they don't always need to be complied with. And legally what makes these different is you're not committing a battery if you refuse to do what the parents want you to do. In this case, they're asking you, in many cases, to go either beyond or actually in conflict with what you believe to be in the best interest of the child, and they can't make you do that. So as a professional, you are perfectly within your rights to say, I think this would harm your child and I'm not willing to offer it. And this applies to many of the cultural requests we get with alternative and complementary medicine. I think the most solid grounds we have for refusing requests, so again, I think most of the time we should try to work with parents. If their request is one that's not going to hurt their kid, maybe we should just let them do it rather than fight this battle. And so I'm perfectly happy, sort of accommodating requests that don't put the child at risk. But when the likelihood of harm to the patient greatly exceeds the likelihood of benefit for what they're asking, I think we can refuse. When it falls outside the realm of accepted medical practice, I think we can politely refuse to do those things. When it falls outside of the realm of your expertise, that has certainly not infrequently afflicts me in the emergency department. A parent wants me to prescribe a psychotropic medication and it's one I've never written a prescription for. Probably not going to do that. I'm going to send them to somebody who actually knows what they're doing when they write that prescription for that medication. The intervention would not work. We don't have an obligation to do things that are truly futile. Or if cooperating with the request would actually harm someone else, maybe other than the patient, like present a public health risk or be a poor use of available resources. And then there are conscientious objections, which we won't spend a lot of time talking to, but most of the time should probably be respected as long as the patient can remain cared for by somebody in the institution. So my suggestion with these situations is to consider accommodating parents when it won't hurt their child, when it won't significantly harm others, and especially if there's some potential for benefit that's possible but not established. And again, another limiting factor is what's within the range of your practice, because that certainly is an important consideration here. So one final note, in all of these cases, particularly the refusal where parents refuse, the procedural justice is important. There should be a mechanism for resolving those disputes that's fair, transparent, and inclusive. Many institutions have ethics committees. That's one of the roles for those committees and consult services is to help adjudicate these sorts of disputes. And in some cases, if they can't, in some cases actually help solve them. If they can't help solve them, then help the team determine when perhaps you do need to involve the legal system. So what I want to end with is sort of my little way of thinking about these disagreements and maybe give you a slightly different way of thinking about why people disagree about issues like this and how that may help you work with families a little bit differently and make them a little less about the conflict and a little more about what those of us in medicine usually do quite well, which is solving problems. So I'm going to get at this by talking a little bit about the Shiprock, which is a spectacular mountain in the deserts of New Mexico, northern New Mexico. And the Shiprock is, it's actually the core of an old volcano. So what you're looking at here is the lava core that's left behind after the volcano. The walls of the volcano have eroded away. It rises 1,700 feet off an otherwise flat desert floor. You can see this thing for miles and miles up in Mesa Verde National Park when you're up on the Mesa Verde Plateau, which is about 70 miles away. You can see it sticking up way off in the distance. I mean, it's really quite an iconic structure. And it's an icon for the Navajo Nation. It sits on their land, and the Navajos consider this to be one of their sacred mountains. And it's sacred in Navajo lore, in part because it was this mountain that rescued them from their enemies. So many people who know about the Navajo recognize that anthropologists are interested in where they came from. There's fair agreement among anthropologists that they did not originate in the southwest U.S., that they probably came over the Bering Strait from Asia at some point in a migration. Well, what the Navajos believe is they did come from somewhere else to this land. And they did so because they were fleeing enemies. And what saved them from their enemies was this flying vessel that took them and landed them in the Southwest. And that vessel, the remnants of that vessel, is the Shiprock. So they worship the Shiprock. It's a sacred mountain for them. It's also a sacred mountain to some, in a different sense, to the rock climbing community, because these fluted walls pose quite a challenge. And for many rock climbers, this is just one of those notches they want on their belt. You got to climb the Shiprock. And so they come from all over the nation and even the world to climb the Shiprock. Now, that puts them in conflict with the Navajo, because the Navajos say you don't climb a sacred mountain. And so what you have to some degree is a moral disagreement between these two individuals. Now, there's a third group, and that's me, the photographers, and this is not the greatest photograph of the Shiprock, but it's the one I had. And the photographer actually sees this mountain as a thing of beauty and attempts to capture it in certain ways to illustrate that beauty. Now, when I think about how people make moral decisions, I don't think about Kant and Mill and all this stuff you don't want to hear about today. I think about how they make moral decisions. And most of us, when we think about ethical issues, we think about the action-response level. So ultimately, you got to make a decision, right? So the Navajos worship the mountain. I photograph it. The rock climbers climb it. That's the action and decision. Well, how do you come to those sorts of decisions? For most people, there are two major components that fit into that. And if you really want to understand why somebody has come to a different conclusion than you have to understand those two sides of the coin. The first of which is their character and identity, and the second is their vision. Character and identity is really just the way somebody sees themselves. So the illustration I've given you is a great example of that. When you are a Navajo, your sacred mountains mean something to you. You're not a good Navajo if you don't recognize the Shiprock as sacred and you don't treat it respectfully and behave in a way that treats it respectfully. If you're a rock climber, you can't not climb this thing. I mean, you have to climb it. It's part of your identity. It's who you are. You can't look at something like the Shiprock and say, let's just enjoy this thing from here. That's not in their DNA. And as a photographer, I want to capture it in a different way. I just look at it differently. So character and identity plays a big role here. And you can see how that, you can see it in Dennis Lindbergh's case, right? Being a Jehovah's Witness means certain things to them. And it's part of your identity to not accept blood. So part of it is identity, and understanding where somebody is coming from in terms of who they are can be important. In some ways, very difficult to, often what comes part and parcel with that, but not entirely, is this notion of vision. And what I mean by vision is, it's really about the way you see the world and understand the world. And again, you can, to the Jehovah's Witness, there's a certain understanding of what blood means. But think about the Navajos. When I show you the picture of the Shiprock, I mean, this is what you see, right? We all see the same thing, but we don't all see the same thing because our brains invest what our eyes are seeing with meaning. So, the geologist will tell you what this is made of and give you all kinds of structural analysis and all that kind of stuff. But when the Navajo looks at this, they see a sacred mountain. And when the rock climber looks at this, they see a challenge. And when I look at this, I see a photographic opportunity. So in many ways, we're all seeing something different. And our vision profoundly affects the way we behave. When you see a sacred mountain, you stand back in awe. When you see a challenge, you make a beeline for it. When you see a photographic opportunity, you drive around the thing looking for the best angle and the best lighting and all of that kind of thing. We all behave differently toward the Shiprock because we see something different. And that notion of vision is a really important one. You know, one of the better ways for understanding the power of vision is just in a tale some of you have probably heard about, a battleship that was out on maneuvers, and conditions are not great. There's a fog coming in, it's getting dark. So the captain comes up and joins the lookout and says, how are we doing? And the lookout says, well, I'm concerned. There's a light on our starboard bow, and I think we're on a collision course with that ship. So the captain says, well, signal the ship to change course 20 degrees. So the battleship signals change course 20 degrees, you know, using their lights. And the light blinks back, you change course 20 degrees. So the captain is not pleased and says, signal that ship, I'm a captain, change course 20 degrees now. And the light blinks back, I'm a seaman second class, you change course now. And the captain is now livid, and you might argue blinded by fury, and says, signal that ship, I'm a battleship, change course immediately. To which the other light responds, I'm a lighthouse. So who do you think is going to change their behavior now? What's happened there, in my paradigm, is that the captain has had his vision corrected. As long as he believes that's another ship, he's not backing down. Once you have clarified for him what's at stake in a way he can understand, he will change his behavior. Vision is profoundly important in terms of the way we approach the world. If you don't believe me, look at the way people talk about contentious issues. Pick any of them. We have them daily right now in our country. And the way one side describes it is it's almost difficult to believe they're talking about the same thing as the other side. Think about abortion. Is what's at stake a fetus, an embryo, a clump of cells, a baby? The way you describe it tells you a lot about how a person sees that issue. Physician-assisted aid in dying. Well, is it physician-assisted suicide? Is it aid in dying? Is it the relief of suffering? The way you describe something tells you a lot about how you see what's going on. And the odds are you will never be successful at changing somebody's mind about any issue if you don't figure out, first, how they're seeing that issue, and secondly, whether there is some way to work within to either correct their vision, or if you can't do that, to work within their way of seeing things to convince them that some other action might be appropriate in this case. So the last example I will leave you with was with a case that I was involved with, again involving our oncology team. And in this case, we had the son of a recently immigrated Russian family. And dad would not allow his son to be treated for cancer. And his reason was, I don't believe he has cancer. And you know, most people's response to that was, you know, and when you get the ethics consult, this is kind of what you hear. This dad is out of his mind. He's nuts. So, you know, diagnose the problem. Why does he think that? Well, as it turns out, maybe he's got some pretty good reasons. He has come from Russia, where he tells you, when you actually take some time to sit down and listen to him, that he had two relatives in Russia who were treated for cancer, who were subsequently found not to have had cancer in the first place. They were treated unnecessarily. Now, you and I aren't going to be able to discern the truth of that, but the fact of the matter is he's had some life experiences that make him believe doctors misdiagnose cancer. So he's not buying it. So he's refusing chemotherapy for his son. We ran through the harm principle, you know, checklist that I showed you and came to the conclusion that it would be justifiable to involve the state and get a court order to force treatment. But there's an eminence criterion there. So my question to the oncologist was, how long do we have to work with this family until the prognosis deteriorates? And he said, about a week. And I said, well, then you got a week to figure out how to convince this dad that his child has cancer. And on day 7, to his credit, he took the dad down to the path lab, and he sat in front of a teaching microscope with the dad on one side and he on the other, and he pushed over a picture book with pictures of cancerous white blood cells and non-cancerous white blood cells. And he spent a great deal of time having the father look at the microscope, and the father would go back and forth between the book and the microscope. And finally, the father turned to him and said, "My son has cancer. You need to treat him." A great example of how, in that case, the diagnosis was, we have a vision problem here, and we have a way to fix it. And we did not need to get a court order. We had a family that was eternally grateful that we had spent the time and taken the effort to work with them. And we now had a very compliant and cooperative and therapeutic alliance going that would allow this child to get treated effectively, which would probably not have been the case had we immediately gone to court and sought a court order. So again, sort of understanding what goes into the way people make decisions can sometimes, I'm not going to say always, but can sometimes help you figure out how to solve these problems without involving the state. So I'm going to stop there, and I think we have a few minutes if people have questions or comments.
Hey, Doug. I have a question, maybe more of a request for a comment than a question itself. We've had a couple cases where an oncology patient will come in, clearly would be defined as someone that has a good prognosis, 95% survival with reasonable chemotherapy. Parents try to refuse, but then ultimately are forced into a starting therapy, and they do so only to stop after a month or two. And now the risk of death has gone from 100% to maybe 50% because they've been partially treated. So have you run into that situation, and okay, what do you do? What do you do with those?
I haven't personally been involved with a case at our institution where that happened, but I'm certainly aware of others where it's happened. And what I would say is you do the same thing we just talked about. In other words, so what you're talking about now is, again, if you sort of think about the legal framework, the state initially gave you the authority you need to treat this kid, but now presumably, if that authority if that authority is still in place, you keep treating him. But if you need to go back to the court after a month, it's their call. And so your job as an oncologist is going to be to convince the judge that 50% is still enough to justify this. And the one thing we can't control is what an individual judge is going to do, or an individual CPS worker, if that's the route you go. And for most of these oncology cases, my experience has been that they actually go to a judge. For most of our ER cases, it's calling CPS because you can't get a judge on the phone at 3 o'clock in the morning, at least not where I live. They actually told us to stop calling and do it a different way several years back. But, it's still the same question. It's just that the numbers have changed.
It seems that in the case that you started out with, that starting the chemotherapy put the child at risk of death, probably hastened the death. And when, as you mentioned, it wasn't clear how well the circumstances were laid out to the parents. Was that something that was thought about? And what are your thoughts about the role of...
and everybody always asks this question. Sometimes I just jump in and tell you not to ask it. Because I actually don't know what discussion occurred in that room, but it's the first question everybody always asks about that case. Well, didn't they talk about a transfusion before they gave him chemo? Knowing the characters involved, I'm almost certain they did at some level, and my guess is that like most of the conversations we have with parents, they don't actually hear everything. What they're hearing right now is, my child has cancer, my child has cancer, my child has cancer, they need treatment, they need treatment, they need treatment, and the little bit about all of the things that go along with that just kind of gets lost a little bit. And so, giving them the benefit of the doubt, I have to assume at some level it was discussed, but there was probably never an explicit consent to blood. And, quite honestly, even if they had, consent is something you can retract. And so in some ways, it doesn't matter anymore, other than in sort of debriefing the case and talking with the team and saying, how can we prevent this from happening the next time? Correct. And I actually don't know if they knew that coming in either, because not everybody conveys that to the healthcare team, unless they think it's going to be relevant, and they may not have.
Yeah, Doug, so I see you've outlined sort of a set of standards about bringing the clinicians up to the point of sort of getting on the phone. You're looking at these cases, and with your experience, I wonder if you might comment on what happens after that. Do you think the process is fair and balanced? Does the system tend to weight the physician's authority more heavily than the parent's input? What's your experience about the nature of the process after that phone call?
Yeah. Well, I think it's hard to answer that question because it's so, particularly if you're talking about getting a court order, you're going in front of a judge. And what I will tell you is that the judges I know hate these cases. They would rather they not come to them because they just don't like being put in a position where they have to make a choice between what a parent makes, because that looks bad if they tell the parent they can't do something, or letting a kid die. They just don't want to be in that position. So judges hate these cases. And a lot of it, I think, hinges on how persuasive the medical team is and what the factors are and who that judge is. And it quite honestly, and this may get to some of the fairness, if you have a set of articulate parents, they're going to be much more persuasive to a judge than parents who just can't, they maybe don't have the educational level where they can use the words that a judge gets. So, you get two well-educated, college professors who are parents in the room, and a judge is much more likely to sort of side with them than maybe a poor family who neither parent has a college education, and they just know they don't want this. So, that's not really a great answer to the question, but, when you look at the court cases out there, other than that, it's hard to find a case where where life is at stake and the odds of helping a child are above 50 or 60%. There aren't many cases where judges side with families there. But when you get down to 10 to 20%, there aren't many where they side with the medical team in life-threatening cases.
I think we're going to need to wrap up. I want to thank the medical staff office for supporting this lectureship, Dr. Green's family for coming, and Dr. Bodkin and Dr. Diekema. Thank you.
Yeah, thank you.